Welcome to each one of you to this very interesting course, which is probably like a continuation of Mahesh's previous course. We are taking a new look at an old foe, endophthalmitis management in the current era. We have crossed 30 years after the results of the landmark trial. The endophthalmitis vitrectomy study was published way back in 1994. Since then, we have seen a lot of changes with respect to the epidemiology, the pre-surgical infection prophylaxis. We have new bugs, new drugs, new technologies pertaining to diagnosis of endophthalmitis. We have standardized procedures to deal with cluster endophthalmitis. We have new entities like post-injection and post-vitrectomy endophthalmitis, and a lot has happened in the management of culture-negative endophthalmitis. This is the course format. Epidemiology and standard pre-surgical infection prophylaxis will be dealt by Dr. Shalini Mohan from Kanpur. She's an upcoming anterior segment surgeon. Welcome, Shalini, come up onto the dais. New bugs, new technologies, new drugs will be dealt with somebody who heads the largest VR unit in our country, Dr. Naresh Babu, who heads the Retina Clinic of Arvind Eye Care System, Madurai. Post-injection endophthalmitis and post-vitrectomy endophthalmitis will be dealt with by our president, outgoing president, Dr. Mahesh, who heads the VR unit at Giridhara Institute. And management of culture-negative endophthalmitis will be dealt with by our past president, Dr. Thomas Cherian, who heads the retina unit at LF, and I'll be dealing with cluster endophthalmitis. Dr. Shalini, the podium is all yours.
Thank you so much, Dr. Meena. Indeed, it's a pleasure to be part of this course. And at the outset, I will thank Dr. Arup sir for allowing me for this presentation. So, just now, I was allotted this topic of epidemiology and standard pre-surgical and peri-surgical infection prophylaxis. So whenever we have endophthalmitis, it is one of the dreaded complications after any intraocular procedure, of which we all are scared of. So let's see the epidemiology. Once we talk about US, it is 0.04% of cataract surgeries and 0.016% of patients receiving an intravitreal injection. When we talk of England, it is 63% of cases which are associated with intravitreal injections, and while cataract surgery accounts for 17% of cases. Now in Asian countries, the epidemiology is slightly more. Reported incidence is 0.023% to 0.076% in post-cataract cases, and varies from 0.01% to 1% in post-intravitreal infections. Let's see of our own country. Now because of introduction of intracameral antibiotics, the incidence is now low, 0.02% to 0.15%, and it is increased with combined procedures like vitrectomy or pars plana vitrectomy. Secondary IOL implantation seems to be at higher risk, and trabeculectomy even much more incidence of endophthalmitis. When we talk about different types of intravitreal anti-VEGF injections, it is similar. So let's see how does this happen, then only we can manage this particular situation or prevent it. Source of infection is gram-positive bacteria, especially coagulase negative staph. Major periocular reservoirs are eyelid, lashes and conjunctiva. And bacteria can enter the eye from multiple other sources also, like aerosolized bacteria, contamination of various consumables, etc. So what should we do? So there are multiple guidelines and reviews available. Two of these systemic reviews, which were actually very good and with practical implications, I have incorporated. Now this was a clinical guidelines published between 2008 to 2023. They scanned 110 articles, 431 articles were screened, out of which 20 eligible studies were set for data extraction. Now this is the just this month published article from our own country in American Journal of Ophthalmology, which highlights various consensus guidelines and very practical article. So on the basis of these articles, let's see what all we need to do. If you see a patient like this, with eyelids like this, we have to maintain the lid hygiene and disease management, never jump for surgery in these patients. Treat blepharitis, do lid scrubs, warm compresses, topical antibiotics like azithromycin, oral doxycycline. Manage acute and chronic dicryocystitis, avoid any concomitant procedure with cataract surgery, and check for any infective foci. It might be an abscess, it might be a dental infection, and then of course control systemic diseases like diabetes and anemia. Now, once we talk about preoperative antibiotic prophylaxis, of course, it reduces the bacterial load of conjunctiva, but the strong evidence to support its efficacy is actually lacking. When we talk about ASCRS survey, 90% they use topical antibiotics, but recent guidelines say that 3 days preoperative antibiotic offers superior efficacy compared to shorter duration of 1 day or 1 hour. So preoperative topical antibiotics is used everywhere worldwide, and we also use it. Let's talk about skin and surface antisepsis. Now this is very critical preventive strategy to use antiseptics before interventional eye procedure. Application of any type of antiseptic, it might be povidone iodine, it might be chlorhexidine, reduces the incidence of infection. Almost all guidelines, they recommend conjunctival sac installation of 5% povidone iodine. But the question is, for how long? And on that basis, AIOS guidelines, they say that application of povidone iodine 10% on skin and 5% in conjunctival cul-de-sac for 3 minutes is adequate and supports strong evidence. So if there is allergy to iodine, then we can resort to 0.05% of aqueous chlorhexidine. So thus we are preventing infection without encouraging antibiotic resistance. Surgical draping is extremely important. Initially the lashes were cut, but now the recommendations are not. So you have to cover all the eyelid margin and lashes with the help of your eye drape. If it is a pre-cut drape, it is okay, otherwise you can do it yourself. And make sure that all the lid margin and eyelashes are properly covered underneath the eye drape. This is an important and mandatory step to pursue. Now, what about consumables during surgery? So, topical anesthetic eye drops. Be very, very careful. In every OT, please open a new vial of any anesthetic eye drops. Never use a drop which has been previously opened. Surgical blades, new for every case. Autoclaving instruments in between. So, use flash autoclave or have multiple sets. Phaco-tip and bimanual, if you can change, it is extremely good. Now this is an article from British Journal of Ophthalmology, published in 2025 only, and gives very good practical tips, done on 85,000 of sequential cataract surgery. What they did, they divided into 2 groups, 1 and 2. In group 2, they gowned each patient, they changed the surgical gloves, they changed OR floors and counted after every patient, and only 1 patient at a time in OR. And the other set of group 1 patient, in those patients, all these processes was not done, although the gloves were sterilized, but they were not changed. So what they concluded is that adopting these 4 set of temporary OR protocol is often not mandatory in Western world and did not reduce the incidence of post-operative endophthalmitis. So the practical tip is very good about this article. Now coming to another very important and pertinent topic, which is intracameral antibiotic prophylaxis. According to 2014 ESCRS survey, intracameral cefuroxime reduces the risk markedly as compared to topical therapy alone. And 74% of respondents, they regularly employed intracameral antibiotic prophylaxis. And most of the guidelines, they suggest. Now, what about other antibiotics? Because cefuroxime is not available in our country. This article highlights very good about other antibiotics, which took 51 eligible original articles, and they said that intracameral injection of vancomycin, cefazolin, cefuroxime and moxifloxacin, they all are equally good and they prevent post-operative infection. So the evidence from our own country by Dr. Haripriya et al. Say in more than 6 million of cases that there was reduction of significant endophthalmitis with intracameral moxifloxacin use, and because the MIC achieved its 10 times and therefore it remains bactericidal for much longer duration of time than cefuroxime. Moreover, it is available in our country also, and subsequently ASCRS issued a clinical advisory on intracameral moxifloxacin in 23 and recommended a dose of 0.5 milligram achievable by using 0.1 ml of solution. So this was the graph from Dr. Haripriya et al. Study. Finally, I would say wound closure is extremely important. Watertight wound closure is the crux. We don't want any hypotenuse eye in which the water seeps in from outside inside the eye. In case you are doing some complicated case and you are unable to hydrate the wound, never forget to put one suture. It is always good. And after completion of surgery, when we talk about immediate antibiotic eye drops, there are no fixed guideline, although certain areas fluoroquinolones are the choice of drug. But post-operative, after 4 to 6 hours, when there is waning effect of intracameral antibiotic, don't forget to start the antibiotic eye drops. So what is the duration in post-operative period? It might vary 1 week, 2 weeks or 4 weeks depending on your geographical area. But antibiotics should never be tapered to avoid any resistance. So the basic factors we need to take care about: instrument sterilization, operation theater should be fumigated, the airflow, OT, temperature, humidity should be monitored. So the take-home message is that intracameral antibiotics are most reliable to prevent endophthalmitis. Long-standing role, highest quality evidence favor povidone iodine 5% in the conjunctival cul-de-sac. Watertight wound hydration is extremely important, and post-operative antibiotics should be instilled, although they have moderate evidence for the benefit. Thank you so much for your kind attention.
Thank you, Dr. Shalini. We will take up your questions at the end of the session. I'll request Dr. Naresh to give his presentation on newer bugs, newer drugs, and new technologies in the management of post-operative endophthalmitis.
Thank you, madam. Thanks for the invitation. And just a disclaimer, actually. See, most of the organisms which we'll be presenting are from our library. But during my microbiology, I have not gone through these organisms. So I will not be spelling or pronouncing them properly. So just don't make fun of me when I am pronouncing wrongly. Okay? So if you can pronounce correctly, you can tell me. So a lot of things has been discussed about endophthalmitis and its epidemiology. Just to brush up, it's basically because of the colonization of the organisms in the vitreous cavity. And we have a lot of classification. And sometimes we may get a case of endophthalmitis without pain. That is in almost 25% of the cases. Still we have to suspect. And there need not be any hypopaean in 15% of the cases. Still you have to suspect endophthalmitis. Especially in case of fungal, we rarely see endophthalmitis. These are the usual organisms. This is how we used to deal with. But we'll be discussing more of unusual organisms which we have come across during our practice. It can be both gram positive or gram negative. And if the virulence is slow, especially in case of cluster, it's a disaster because it grows slowly, difficult to identify. Then the long course and the antibiotic resistance all lead to a negative outcome in these cases. Then some of the highlighted organisms are the one which we have come across in our practice as a rare bugs. And some are clusters, of course it might overlap, but I will not be going in detail. So identifying is not that difficult, especially in case of cluster. If the organism is rare, it is easy to identify. If the organism is common, it's very difficult to identify. So one first thing is this Chytococcus sedentarius, the patient came, and the patient, the organisms was resistant to almost all the drugs. So he came on 18th post-op day with light perception, all the features of endophthalmitis. This is how we started. And all cases we admit on day 0, we go for intravitreal antibiotics, because if the patient comes late, we don't want to have any delay in that. And if needed, next day, the core vitrectomy is done. So the patient underwent core vitrectomy with the intravitreal voriconazole, Vanco and Cefta. And patient was doing fine. But again, after a few days, he came with, again, drop in the vision with PL. This time we have done the re-core vitrectomy. So the main idea is whenever there is a re-core vitrectomy in all these cases, or in case of gram-negative, or in case of fungus, we go for silicone oil injection, retain the silicone oil till the inflammation and the infection completely reduces. And this patient could get a vision of 6/60. This is Cocuria, I think, and this is one of the rarest organisms which we have never come across commonly. And this was a patient, but this is a post-injection endophthalmitis. So after the diagnosis, core vitrectomy, everything was done, and patient could get a vision of 6/60. These are the other organisms. Coming to gram-negative serratia, this is one of the organisms, not that rare, but not very common also, but very easy to identify. Any patient who comes with a, what you call a pink hypopaean, without doing culture, you can say that patient is having serratia marcescens. And this is one of the cases where a 11-year-old boy came with this organisms, outcome was good. And we had a very unfortunate, what you call, situation of treating some of the cluster endophthalmitis. This was, we have published only 13 cases in this series, but the numbers were very high. So this was Burkholderia cephacea. It's almost similar to Pseudomonas. Many lab might misdiagnose this as Pseudomonas, but this is a separate entity, very slow growing. And this has happened because of the contamination of the topical anesthetic agent which was used. So the topical anesthetic agent also grew, and it was analyzed, and it is the same organism. And in this case, we have gone for piperacillin tazobactam. So nowadays, piperacillin tazobactam 225 microgram is our drug of choice in case of any gram-negative antibiotic. If it is very resistant, we go for colistin. And in most of these cases, you can see here a patch graft was done. And in 13 cases, most of them retained vision of 6/60 or so. And if you take all the cluster endophthalmitis, fortunately, we had the best outcome among all the Burkholderia cephacea. The second rare negative organisms was Ochrobacter anthropi. This also I came across for the first time. And we had 4 cases from the same institute, again a cluster. So in all these cases, I think 2 of the cases, as soon as we got the culture, we went ahead and we removed the IOL bag capsule complex. So when we are removing the IOL bag, every single, what you call, the remnant of the capsule should be removed, so that there is no multiplication. And most of these cases did very well. And this is not a post-op, but still would like to mention, we had a very rarest organism, that is Vibrio cholerae, coming to us with endophthalmitis. This was diagnosed based on culture. This patient neither had watery stool nor watery discharge in the eye. He came with just a beak injury. But if you see the outcome after the, what you call, this was the final outcome, where you can see the whole retina is crumpled over the disc with the bare choroid. The patient was just PL, and the outcome was very bad. These are the other gram-negative which we have come across in our practice. Most of them were fortunately responding. The last we'll be talking about a small cluster. I cannot say it as small cluster. 12 eyes of 10 patients. They all came with Candida pelliculosa. So this is also never reported so far, pelliculosa causing acute post-op endophthalmitis. All of them came within 15-20 days after cataract surgery, but we could not identify the source. But once it was suspected fungus, in all these cases, you can see the vision ranged very good from 660 to 6/9 at presentation. So we had a lot of problem in convincing them to go for IOL explantation. We have done IOL explantation in all these cases. After 4 to 5 months later, we have started implanting. I think 8 out of 12 eyes we have implanted the secondary IOL Gabber's technique, and almost all the cases regained very good vision. So again, in case of any suspected fungal, whether it's Candida pelliculosa or in case of gram-negative, the first line of treatment is go, remove the IOL, bag, CTR, everything, gives a good outcome. And in case if it's gram-negative, it's virulent, silicone oil is our choice. So these are the other species. So just for next 1 or 2 minutes, we'll just see how to diagnose. B-scan is a must because this differentiates stars also. We can go for AC tap as well as vitreous tap. And the route of administration depends. Intravitreal is the most important. But we have to remember that when you are removing the lens, there are certain antibiotics like vancomycin whose half-life is reduced. And when you are removing the vitreous, there will be reduction in the half-life of beta-lactams and the fluoroquinolones. So we'll have to increase the frequency of intravitreal injection if they are responding. Like in case of voriconazole, the half-life in the vitreous cavity is just 5 to 6 hours. So every 2 days repeating voriconazole in case of fungus is not a bad idea in case if the patient is responding. And I don't have any financial interest. I think every cataract surgeon can have this. This is just 1,500 rupees. It has got all the drugs, vancomycin, voriconazole and dexamethasone. They say it is a single dilution, but I'll prefer a 2-stage dilution. No mathematics involved, just dilute, take 0.1 ml, inject. This can be done by every one of us, including the anterior segment surgeon. So before you refer, have this kit. If you suspect, inject and then refer. Injecting vancomycin and ceftazidime, even in normal eye, is not going to cause any problem because we have got a very high dose of tolerance in case of vancomycin. Up to 6 milligrams can be given without any issues. So as far as vitrectomy is concerned, it's always told core vitrectomy, but we prefer complete vitrectomy where you go for induction of PVD but don't induce beyond the equator. So this is some of the situation where you don't go beyond the equator, but you have to be very careful when you are inducing the PVD. I think it's not working. So when you are inducing the PVD just from the disc, especially nasally, even if there is any collateral damage, there will not be any damage to the macula. And don't go beyond equator. If needed, we can go for silicone oil injection in these cases. There are certain challenges. For want of time, we'll just skip. These are the poor prognostic factors, especially the most important thing is gram-negative organisms on smear usually goes with poor outcome. And if there is no worsening after the injection or if there is no response to antibiotics, then the outcome is bad. So finally, when you're doing vitrectomy, we have to go for the high cut rate with the minimal suction. Silicone oil, especially in case of gram-negative because of its antimicrobial property, as well as it compartmentalizes the infection and it also prevents the thing. So basically, after we started using all these intravitreal antibiotics, now we are emerging with new organisms causing endophthalmitis, and we also have a lot of drug resistance. And in case if you are doing core vitrectomy, if you are very confident, we can go for a complete vitrectomy, especially a prompt vitrectomy and a prompt referral is mandatory so that we can achieve good functional outcome. Thank you, Answering. Thank you, madam.
Thank you, Dr. Naresh Babu. Again, we'll have a few questions towards the end. And next is Dr. Meena Chakravarti. She is one of the senior most practicing vitreoretinal surgeons in India. She is the heart and soul of this instruction course. She'll be dealing with cluster endophthalmitis.
Thank you, Thomas. In the August of 2018, I had the fortune, or I would rather say the misfortune, of dealing with a cluster endophthalmitis referred to be my colleague. I had 4 patients who had endophthalmitis, all had undergone surgery on the same day, and everyone proved to be culture positive for Acinetobacter baumannii infection. So if you look at this pathogen, it is a gram-negative Coccobacilli, which belongs to the Moraxiliaceae family. It's a red alert pathogen, and it is part of the escape group of organisms which cause very severe nosocomial infection. It is ubiquitous, present everywhere. It can be a normal flora of the perineum, the oropharynx, and it can also grow on antibiotic eye drops. It's a multi-drug resistant organism causing recalcitrant infection. So I thought I could collect all the records by retrospectively analyzing my case sheets and present to you. All the 4 cases operated at the same center, presented at varying periods of time from 2 weeks to 4 weeks after the primary surgery. The best corrected visual acuity was not more than hand movements in any of these patients. They had either chalky white or gelatinous brownish dirty colored hypopyon. One patient had a limbal infiltrate and one patient had a partially steroid responsive. She had already undergone a vitrectomy. Her capsular bag had sequestered organism. She had an epiretinal membrane and macular edema. All the patients were culture positive for Acinetobacter baumannii infection, which is sensitive to ceftazidime, ceftriaxone, cefperazone, piperacin tazobactam, and I decided to give ceftazidime. They underwent an average of 8 biopsies. Each time the biopsy was positive for Acinetobacter baumannii, the aqueous, the vitreous cavity, the explanted IOL, and the capsular bag were all sent for culture. An average of 8 intravitreal injection was given, initially vancomycin with ceftazidime, followed by ceftazidime alone. An average of 4 vitrectomies was done in each of these cases. Case 2 and case 4 an epiretinal membrane peel, and 1 case had persistent hypertony in the postoperative period and needed a silicone oil tamponade. I'll share with you the difficulties I encountered with one patient. It is a one-eyed patient, and this was her only eye. The other eye was lost following trauma. I have our data from the 10th month. The first 2 months pictures are not there. This is after post-intravitreal vancomycin, ceftazidime, and 2 episodes of vitrectomy. The eye looks fine. So this is in the 11th month. You can see the gelatinous dirty white hypopyon collecting in the anterior chamber. The posterior chamber, surprisingly, had very little inflammation. It was confined mainly to the anterior segment. I tried advising her to undergo an IOL explantation. Since she was one-eyed, she did not want to give up her lens. So this is in the 11th month, after again another intravitreal injection and topical ceftazidime antibiotic drops, her inflammation subsided. She came back again in the 12th month with recrudescence of the infection. This is the 12th month picture. The same thing in January, and by February I had almost given up. I told her that we have to explant the IOL, and then she agreed. This is what the eye looked at the time of IOL explantation. You can see the amount of muck in the anterior chamber. It's like a cocoon in the anterior chamber, and when you puncture it, you can see fresh exudate coming out of it, as if the entire thing is coated with a fibrin membrane. She had a single piece hydrophilic acrylic lenses implanted in the bag. There was a lot of addition between the iris and the IOL. The IOL is brought out of the capsular bag, and in these situations, you have to explant the IOL together with the entire capsular bag. Try to carefully remove the entire capsular bag. With the organism may be sequestered in the capsular bag in the ciliary sulcus, and it can grow again and cause recrudescence of the infection. So the IOL comes out. It is cut and explanted. The anterior chamber is cleared. I've already taken a biopsy again at this point of time, both from the anterior chamber and from the vitreous cavity, and you'd be surprised to see how at the end of the surgery, how clean the eye looks like. The eye is basically white. There is hardly any congestion or chemosis in this patient, and there is no discharge also. And you can see there's a red glow also in this patient. This is in March. She had a best corrected visual acuity with FAK correction of 6/24, and we could get some fundus view. So these are 4 culture-proven cases, all at post-surgical, post-cataract surgery endophthalmitis. They underwent multiple intravitreal injections and posterior segment procedures. Case 1 ended in phthisis. He somehow gained enough confidence in our center to have the other eye operated for us, and he is doing well. Case 2 I have already discussed. Case 3 ended with a vision of 6/18. Case 4 had persistent hypertony. If you look at the susceptibility of this organism, it varies in different studies, varies with time, varies with the location. Some are sensitive to the fluoroquinolone, some are not. My patients were sensitive to, luckily for me, to ceftazidime, which we can inject both intravitreally and also prepare the ceftazidime eye drops. So I contacted the surgeon and we decided to suspend all surgeries in his theater. We reviewed all his, both of us together reviewed all his protocols. Full assessment of his perioperative protocols, the patient preparation, the operating theater hygiene, instrument sterilization, everything, single aspect, and nothing faulty could be brought out. All traceable materials used during that period of time was collected and cultured, again negative. The environmental sampling from the theater, the air conditioners, the surgical instruments, the operating floor, and the surgical personnel, operating room personnel, everything was done, everything was negative. But when the patient first came to me, the case number 2, we have a protocol in which we examine the patient's eye drops, especially if it's an infected case, and I saw that there was a lot of crusting, and I cut out the dropper of the antibiotic drop and sent it for culture. It yielded something, but the lab reported it as a contaminant. So Acinetobacter baumannii is a gram-negative coccobacillus. It forms a biofilm on all surfaces, especially dry surfaces, the operating room surfaces. It can also grow on the dropper tip of the antibiotic dropper tip. So we have to be very careful when we advocate antibiotic use or other eye drop use for a long period of time. Please check the bottle droppers. So my ordeal ended in March. From August of 2018 to March of 2019, I had literally had these 4 patients eating from my head. Even now, right from the names, I can remember every single detail. 2 of them have done well. One has good vision in his fellow eye, and one is a vision of 6/60 with a little hypertony. I'm replacing the silicone oil every 2 yearly. I thank you very much for your patient hearing.
Thank you, Dr. Meena. Now we have Dr. Mahesh Gopalakrishnan talking on post-injection and post-vitrectomy endophthalmitis. Incidentally, Mahesh Gopalakrishnan is the president of KSOS and he heads the vitreoretinal department at Giridhara Institute, Cochin. Over to you, Mahesh.
Thank you, Meena madam and Thomas. So I will be talking on post-injection and a little on post-vitrectomy and endophthalmitis because many of you may not be doing vitrectomy. But post-injection and endophthalmitis is on the rise because a lot of people are using injection in many indications. So I will go to that. This was a case of 64-year-old gentleman, local panchayat president, who had defective vision in left eye, hypertensive. It was a BRVO, nothing great in the diagnosis. It's a BRVO, and the macular edema was there. So I injected. That time it was, I think, 13 years back. That time there was only 2 drugs. I injected Avastin. So after Avastin, 4 days later, he presented with severe vision loss. And this was the picture. It's very hazy. Disc can be just made out. Anti-segment cells are there, but no gross hypopyon. AT is normal, fundus is. So I injected immediately Vanco and Cefta, and AC tap, and I think vitreous tap was also taken. KOH, bacterial and fungal culture all done, negative. It improved gradually, and after 1 month, with one injection, because it was an early intervention, 4th day, it improved gradually, and after 2 months, this is the thing. In fact, that was a cluster of 6 cases which came over 5 days. This was taken, we allocate it into different vials and then use it, pack it in EO sterilized pouches, and we use it continuously. It was 6 cases, along with others who 11 cases did not have any problem. So culture of vitrectomy cases showed staph epidermidis. This was the organism. And this other cases, first case presented on 8th day. That is very important. If the patient comes little late, it will finally end up with vitrectomy and intravitreal antibiotic. Very early presentation, 5th day, intravitreal antibiotic may be enough. And so all the cases were managed. We could save all the cases with many of them having good vision. So there are some learnings in this case. One is, unlike post-cataract surgery endophthalmitis, the inoculum that you inject inside is very less. Post-cataract surgery endophthalmitis may be from the instrument or from the fluid. So you inject a lot of organisms into the eye and it will be very severe. Number two is, it is mainly posterior segment manifestation, not anterior segment like a cataract surgery, where you will get a lot of hyperpen, corneal edema, secondary glaucoma like that. So here they present with increase in floaters and blurring of vision first, and not like pain and corneal edema and IOP rise. So immediate management yields good result. So that is main thing. If you wait for 1 week, or 2 days, 3 days, 4 days, it will end up with vitrectomy. Otherwise, it can, many of them are low virulent organisms and you can save the eye with injections only. And this is important in another aspect. Many of us see the patient after injection next day. Most probably the next day there won't be any issue because the inoculum is very small. Patient may not have proper endophthalmitis signs. Usually it comes after 4 or 5 days. So you have to teach the patient that if suddenly floaters are increasing and blurring of vision is there, they have to report and listen to the patient. When they call in the phone, ask them to come immediately. So these are some of the things, and as I always say, medical legal implications are there in using Avastin today. There are cases, the court has said clearly that the off-label medicines are not for use. There are multiple verdicts now. 10 years back, this was not the issue because there were a lot of options. There was no options other than this and one expensive option. Now there are a lot of biosimilars approved for this medicine. So it will be difficult for you to defend in the court of law to defend Avastin endophthalmitis. Okay, number 2, this was a case, this is not a endophthalmitis due to the injection. This is a missed diagnosis. So there was small hemorrhage in the macula, vision was 6/45, and you can see shrum-like picture, pre-RP hyperreflective complex in the OCT below, and it was injected. 1 week after Avastin injection, patient came like this with an abscess in the macula. So what was it? We were shocked actually to see this. There was a choroidal thickness and plenty of vitreous cells and the chemosis, vitritis. Patient gave a history of TB in multi-drug resistant TB many years back, for which he was treated partially and all. So we did every investigation and exciton was done and it found that Mycobacterium tuberculosis. So it was a tubercular abscess which we, in this early stage, we thought it was a CNVM and we injected. That was actually not a, the injection has not done any damage, but it was a misdiagnosis. So this is another point that I want to highlight. Look at the biomarkers very carefully and then only inject. This lot of general comprehensive ophthalmologists are injecting without an indication. I had a CSR patient injected with a biosimilar and patient went into endophthalmitis and panophthalmitis and this was phthisis, and that was a 40-year-old person. So just imagine, these are all difficult to defend, the mistakes that you should never have. So ultimately this became a painless phthisis and later patient also died due to systemic TB. So that is, so don't jump into injections, look for atypical findings, multimodal imaging. So don't think that injections are very, very, it's medical retina is becoming booming in India with a lot of injection companies approaching general ophthalmologists to give injection for anything. Okay. Now the second part of the talk is endophthalmitis after vitreous surgery. It is an uncommon finding, but it's a devastating complication. In 25 years in Cochin, we had 3 cases of endophthalmitis after vitrectomy. All of them we lost. So there are different studies reported incidence of 0.05 to 0.2% across the world. When MIVS started, initially there were reports that MIVS causes more endophthalmitis because the tunnels are not sealed properly. So there were some studies. Vivek Dave and all published in 2014 endophthalmitis following pars plana vitrectomy, a multi-center study. And they found that inadequate wound closure, hypotony, vitreous incarceration, and all these things, including diabetes and trauma, they all were the predisposing factors in post-vitrectomy endophthalmitis. There was a large study by Shankar Nethralaya of 1,11,000 cases, of which 70,000 plus was 20G and later all MIVS. And they found that the incidence is around 2 per 10,000 surgeries, and there are some risk factors in 20 gauge. Actually the number of cases in 20 gauge was more than in MIVS in their cohort, and this was statistically significant. Probably they included all the cases of 1990s and 2000. So, and here also the presentation will be little different. Unlike post-cataract surgery endophthalmitis, the anterior segment findings are will be significant, but the intraocular pressure and vitritis will be more in post-vitrectomy endophthalmitis. The potential predisposing factors in the study was diabetes, vitrectomy for vascular retinopathies, vitrectomy, combined surgery, that is another cataract with vitrectomy. So the risk factor totally changes in combined surgery. Culture proven cases were 53% overall, and most common organism was Pseudomonas. And in culture negative had better outcome than culture positive. Probably because culture positive means there are a lot of inoculum and we are getting culture positive because of that. So that is regarding culture. In their study they said that MIVS does not increase the risk of endophthalmitis. So that was the conclusion from that. Now in the last part is endophthalmitis in silicone oil filled eye. It's a very tricky thing because the inoculum is very, very small, and silicone oil has anti-infective property, and presentation will be like vasculitis and vascular occlusion along with anterior segment findings. So we give half dose intra-oil antibiotic injections, and silicone oil removal with antibiotic wash and re-silicone oil injections are tried. These are all rare things that you may not come across very. Another factors that affect post-vitrectomy endophthalmitis, whether you have put gas, whether you have put silicone oil, and vitrectomy alone, they have a usually violent course. Immediately they will have panophthalmitis with choroidal detachment and other problems. A delay in intervention, if the choroidals develop, it will be very difficult. You can't go inside and do any surgery. So these are some of the. So post-vitrectomy endophthalmitis is a rare but devastating complication, and immediate intervention may save some cases even though prognosis is bad. Thank you.
Thank you, Mahesh. Thomas will be presenting on challenges and recent trends in the management of culture-negative endophthalmitis.
Thank you, Dr. Meena, and good afternoon. We have heard about culture-positive bacterial endophthalmitis, intravitreal cluster endophthalmitis, post-injection endophthalmitis, and now let's go into culture-negative endophthalmitis. Culture-negative endophthalmitis, these are presumed infectious endophthalmitis which pose a huge diagnostic challenge in terms of clinical management. These are not sterile endophthalmitis, just that we did not get a positive culture from our laboratory. A sample is declared culture negative when there is no growth of any organism after 7 to 14 days in any of the culture media. The various studies across India have shown the incidence of culture negative endophthalmitis ranging from 44% to 61%. It also depends on the lab standards which are practiced and many other factors. The possible explanations for culture negative endophthalmitis: sometimes the quantity of the specimen which is given to the lab is very small. There could be a fastidious or slow growing or unculturable pathogen. There could be a prior systemic or topical antibiotic therapy which gives a culture negativity. Sometimes there is a delay in processing the ocular samples. The organisms could be sequestrated in the capsular bag and the IOL. Immunological reaction to scan bacteria, and above all, poor lab practices. The clinical outcome of culture negative endophthalmitis versus culture positive endophthalmitis. Culture negative endophthalmitis has good visual outcome post treatment, which is in a non-infectious toxic insult. Paver et al. Reported treatment success rates of culture negative cases as 60%, and culture positive endophthalmitis lead to change in clinical management intervention compared to culture negative endophthalmitis, where we have to go empirically and based on the clinical findings. So what are the challenges in managing a culture negative endophthalmitis? First of all, is it possible to differentiate from culture positive endophthalmitis clinically? No, because these are also infectious endophthalmitis, and it has been reported that decreased vision, presence or absence of pain or hypopyon or vitritis, and interval between surgery and presentation does not help to distinguish culture positive from culture negative endophthalmitis. That is not the criteria. Failure to respond to incorrect or delayed antimicrobial therapy, further leading to severe inflammation and irreversible loss of vision. Non-infectious etiology like sterile endophthalmitis can sometimes mimic infectious endophthalmitis, making the diagnosis challenging. Now, what do I mean by saying poor lab practices? Many of our microbiology labs use blood bank blood for making blood agar and chocolate agar, and in our situation, most of us have used a lot of antibiotics during our lifetime, and the blood bank bloods will also be rich in antibiotics, and if at all you make a blood agar or chocolate agar with the blood bank blood, these would not grow organisms adequately. So the alternative is collecting blood from the butcher in a sterile way. Sheep blood or buffalo blood can be used to make blood agar or chocolate agar. Nowadays they have artificial media, commercially available artificial media, but still never use blood bank blood, but most of our labs still use blood bank blood for preparing these. That is one of the main causes for getting culture negativity. Diagnostic approach in culture negative endophthalmitis, the comparative assessment of cytokines in culture negative endophthalmitis, vitreous sample analysis of 16 immunomediators as biomarkers was done, and the result indicated that culture proven and culture negative vitreous samples have similar cytokine and chemokine profiles. However, immune mediators like IL, IR1, RA, alpha, and all these have exhibited a significant difference between the culture negative and control group, which was postulated to serve as biomarkers for diagnosing culture negative but presumed infectious endophthalmitis. So this is the flow chart how we manage when we get a vitreous sample. Vitreous sample we send for a smear examination and culture identification. If you get a culture positivity, you do the antibiotic sensitivity. Meanwhile, we would have injected the first line of intravitreal antibiotics, and based on the culture positivity and the antibiotic susceptibility, antibiotic sensitivity, we change the antibiotic as and when required. But when we come to culture negative endophthalmitis, we don't get a positivity, so we go by molecular diagnosis, PCR or next generation sequencing. Sometimes we have to do a real-time PCR, and also biomarkers, the bacterial biomarkers and the fungal biomarkers might help in giving a clue as to what you are facing. The molecular diagnostic techniques, we have real-time PCR, the pan-PCR, and the next generation sequencing. PCR is recommended in culture negative endophthalmitis where empirical treatment fails. PCR and standard cultures are complementary in microbiological identification. PCR offers an advantage of detecting organisms in samples obtained after treatment with intravitreal injections also. So if the patient has taken an intravitreal injection and come to you, your culture might not yield any growth, but your PCR might yield you a result. PCR can detect organisms in pure or diluted samples in 72% and therefore is the gold standard. PCR analysis is the amplification of DNA of microorganisms in clinical samples. We have the pan-bacterial PCR and the pan-fungal PCR. However, a negative PCR does not exclude the diagnosis of culture negative endophthalmitis because again, the sensitivity of PCR is not 100%. When we have a sample, what sample should you take for PCR? We can have an aqueous tap or vitreous biopsy. However, a vitreous biopsy is the best sample because the aqueous quantities are low and the yield is low. Sample has to reach the lab in 2 hours, and if there's a delay, the PCR tubes have to be stored at 4 degrees Celsius for a maximum of 48 hours or minus 20 degrees Celsius if it is longer. Real-time PCR measures copies of DNA in a sample made using a microorganism specific primer. The turnaround time is 2 to 3 hours. The sensitivity and specificity are very high, but sometimes you might get false positivity because there could be a contamination which could again be positive. Unlike a pan-PCR, which takes around 2 to 3 days and it's unable to detect viruses and parasites. The advantage of PCR, we need only a small sample. There is a rapid identification. It can identify the pathogen's DNA even if it is dead or hard to grow. It identifies specific pathogen. When the specific pathogen is unknown, pan-bacterial and pan-fungal PCR can be used. It can even be used in eyes where intravitreal injection was taken. The disadvantage is not a first-line test. If you get a culture positivity, that is the gold standard. The reagent and equipment are expensive. It can give false positive results, and sometimes it can miss some infections. What is next generation sequencing? It can detect different fungi or bacteria present in clinical samples in one single assay. It detects not only the traditional organisms associated with endophthalmitis, but can also identify the newer organisms. Faster results are available than when a pan-PCR is negative. The galactomannan and 1,3-beta-D-glucan, these are polysaccharides. This cell wall component of Aspergillus and filamentous fungi are detected. This can be used as biomarkers in culture-negative endophthalmitis. And what is the treatment of culture-negative endophthalmitis? Just like any other post-surgical endophthalmitis, we take a vitreous biopsy, we do a vitrectomy, we inject the intravitreal antibiotics. In culture-positive cases, treatment decisions and management is altered as per culture reports, while in culture-negative endophthalmitis, we don't have that cushion. We have to go by PCR and NGS and also by the clinical findings which we have. These are the primary antibiotics which we use in managing endophthalmitis: vancomycin, ceftazidime or amikacin as the case may be, and antifungals, amphotericin and voriconazole. These are our first line antibiotics even today. But in culture-negative endophthalmitis, if your patient doesn't respond to these first line antibiotics, for gram-positive we can use linezolid, quinapristine or dalfopristine, daptomycin and tigecycline. And for gram-negative, imipenem, ciprofloxacin, levofloxacin and moxifloxacin can be used. Piperacillin and tazobacter are used in gram-positive and negative and aerobic and anaerobic. And for fungi, you can use miconazole, capsofungin and micafungin where it is resistant to your voriconazole or amphotericin B. To conclude, in spite of limitation of low yield and inability of certain pathogens to grow on routine media, microbiological culture still remains the gold standard for the diagnosis of most intravitreal infections. And the use of molecular diagnostic technique has improved the yield of detection in addition to reducing the time in making confirmatory diagnosis in culture-negative endophthalmitis. Thank you.
Thank you, Thomas. We have about 10 minutes for a panel discussion. We can take up a few questions from the floor. I'll start by asking a question. This is for you, Dr. Shalini. See, intracameral moxifloxacin, the landmark study from Arvind, has shown us that it has reduced the incidence of endophthalmitis from 0.07% to 0.02%. But if you look carefully, moxifloxacin is a drug which is not very effective against gram-positive organism, especially its coverage for coagulase negative staphylococcus is not that great. And the minimum inhibitory concentration that is required is also very high. So do you routinely inject moxifloxacin in your patients, all your patients who undergo cataract surgery, or are there specific cases where you advocate intracameral?
So I inject in all my cases. But yes, there are few articles in which the surgeons, they inject in certain cases where there is high risk of endophthalmitis. Like if there are chances that patient may sustain more of infection, one-eyed patients or associated diseases or systemic problems, then they inject intracameral moxifloxacin. But seeing this particular study, and this was around 6 million of cases, and they found significant reduction in endophthalmitis. I inject in all of my patients, and moreover, we are doing quite bulk surgeries being in government hospital, so I don't want any of the patients to land up in problems, so I inject in all my cases.
And Dr. Naresh, would you advocate intracameral for a specific complicated set of patients, or is it routinely done for all patients at Arvind?
No, but I think at Arvind they do it as a routine. But in case of secondary IOLs, when you're doing SF IOLs, yes, madam, we inject moxifloxacin. But I've got 2 questions for you. You have very nicely shown the inhibition area in case of sensitivity report. Many labs, they say either R or S. So the first question is how important you think the inhibitory zone is important in selecting the
It is
antibiotic?
very important in selecting the antibiotic. The higher the number, the more sensitive the drug. And if it is a drug, you can make either topical drops for the patient or inject intravitreally, you choose that for injection. So you require the inhibition number.
So, but many labs they don't give, so we have to insist on that. My second question is, what is your threshold for IOL explantation? Because you did 2 vitrectomies and then you went for IOL explantation.
My threshold for IOL explantation, if the patient does not do well with the second vitrectomy and at least 2 intravitreal injections, I advocate IOL explantation also. But for this patient, she wanted to wait. She did not want to lose her IOL. So we had no other option to wait. We waited for nearly 6 to 7 months. But if you see her eye, she had very little vitreous reaction. Inflammation was mainly confined to the capsular bag and the anterior segment of the eye. And the eye was also quiet.
Can I add to that? I have an experience of managing a cluster of 36 endophthalmitis way back in 2012. And there I can't afford to have a first vitrectomy, second vitrectomy and wait for the IOL explantation. There I was going by the thumb rule as to how much clinically is the endophthalmitis, is the AC filled with exudates, is there a corneal edema? And based on that I was doing an IOL explantation at that time because I can't afford to do a second vitrectomy and then wait for this.
Mahesh, I have a question for you. This is regarding post-injection endophthalmitis. So initially, most of us give our intravitreal injection in the OT under sterile aseptic precautions, but there are some in-office intravitreal injections that are given in some centers. What is your opinion on masking and no talking policy? That has been found to be the most important cause for post-injection streptococcal endophthalmitis, which do very badly. This is for the benefit of the audience.
In India, as per the guidelines of VRSA and all, it is better to do in an OT or in an area, aseptic area, which is specifically marked for that, where there is no trespass or anything. If something happens and it was given in the OPD, I think it is little difficult to defend us. I don't advise in the OPD. That is, first of all, I don't advise in the OPD because everyone will have some OT setup with them. That is my personal opinion. This is my narration.
No, I have a question for you. Since morning you have been talking about off-label, don't use off-label. But if the patient gets endophthalmitis because of the off-label use of Avastin, we will be treating with antibiotics which are again off-label. So how to defend us?
Very difficult question. But no, I am not telling Avastin cannot be used. Even now we are using Avastin in ROP. Yeah, second part. I don't have. If the patient is, how to answer that? You are caught me.
I'll answer
all
that.
the antibiotics are off-label.
Correct, absolutely.
But we have to treat them with off-label.
Yeah.
So
There you don't have an option. You have to give even if it is off-label. But the other one, in the current scenario, we have other options.
That is, any intravitreal antibiotic is off-label, but for that condition, probably that is the only indication, no?
So if we are using these off-label antibiotics for the treatment and we have literature supporting these antibiotics, can we defend these in law or in court on the basis of the literature which is available?
Avastin. Yeah, you can defend. Actually, we have defended. VRSA has defended in AOS have defended regarding that Nagri case, Avastin. But
what about the antibiotics which are off-label use but they are being used and suppose the patient doesn't respond? In that case, can we defend it?
antibiotic use, suppose you get this in organism and this is only sensitive to this, you have to give that. So there is no option for that. You can definitely defend it. Well, this is a site-saving treatment. You can definitely defend it. But using Avastin off-label in CNVM is little different. There are other options also.
They have rung the third bell. We have to leave the dais. I request both my external faculty, thank you very much for coming. I request KSOS President, the outgoing President, to give Dr. Shalini Mohan a memento.
And Dr. Meena Chakravarti would give the memento to Dr. Naresh Babu. Thank you all. All faculty, please join for a group photograph.